Our next speaker is Dr. Kaustav Basu Thakur. Dr. Kaustav will cover the spasticity rehab portion of the spasticity in SCI patient.
Wishing everyone a good morning to the esteemed guests, delegates, my seniors, faculties, and the honorary chairpersons. Thank you to the organizers for giving the platform to present this topic, the interventions of management of spasticity in especially a spinal cord injury, and it's from a physiatrist point of view. I'd like to start with this slide, which shows the SCI iceberg. So we can see that we know that for an iceberg, only the tip is visible, and most of the iceberg stays below. So this is why the Titanic made a great mistake and sank to the bottom of the sea, because it only looked at the tip of the iceberg. So similarly, at the same thing we can see for the SCI. When a patient comes to us, everyone is concerned with this problem, inability to move. ডাক্তারবাবু নড়তে পারছি না, পা নাড়াতে পারছি না, হাত নাড়াতে পারছি না, everyone is, and they are saying the same thing, the বাড়িতে physiotherapy চলছে. So that is the common thing we face every day in the OPD. As physiatrists, our job is to look at the below the water, the greater part of the iceberg. So being the Carpathia, not the Titanic. So we see that loss of bladder bowel, loss of body temperature, loss of touch sensation, loss of sexual function, digestive health issues, GI issues, cardiovascular problems, neuropathic pain, pressure sores, and last comes spasms or spasticity. So coming to the definition, I won't bore with the classical definition. I've made it very simple. It incorporates mainly 3 points. It is a velocity dependent increased resistance to passive motion, involuntary muscle contractions or spasms, and hyperreflexia. So these 3 points constitute a spasticity. Involuntary muscle contraction results from different muscles acting synergistically, typically in a specific flexion or an extension pattern. Pathophysiology still today is not well understood, but concepts have come up, so like loss of cortical inhibition, which causes the spinal reflexes to become hyperactive, overexcitable motor neurons leading to uncontrolled muscle activity, thickening of muscle tissue due to accumulation of hyaluron, which is the main component of the extracellular matrix, and increased collagen, and shortened resting muscle length, which increases muscle stiffness. So coming to the epidemiology and identifying the problem, we can see that about 65 to 80% of individuals with spinal cord injury, they have spasticity. At the time of discharge, at the time of it usually comes up with within a few weeks to months. So however, there are some risk factors like the level of injury. Usually the cervical and the thoracic injuries have more spasticity rather than the lumbar or the sacral injuries. Completeness of injury, incomplete injuries have been found to be a greater risk factor for the likelihood and the severity of spasticity. And the time post injury, usually it takes weeks to months to appear. So we see that clinical presentation. First of all, we have to how the patient presents. So patient cannot talk about spasticity. They usually come up with the different problems like unable to walk due to inturned foot, or an equinus deformity, unable to stand, ill fitment of the AFO because of equinus deformity, all these things. In the upper limb also, in cervical injuries, there is spasticity of the upper limb also, which inability, with the patient complains that inability to release a grasped object, like that. So goal setting is very important. So we have a smarter acronym which helps us in setting the goal. So S stands for specific. We have to identify the specific problem, target a specific problem, well-defined specific problem. It should be measurable. The spasticity either quantitatively for technical goals and qualitatively for the symptom-oriented goals. Ultimately, we have to have a measurable, the goal should be achieved. Anyways, next comes A, that is agreed upon. The doctor, the patient, the caregiver should agree upon the outcome of the patient or the outcome of spasticity. They should work together towards a common goal. Then the goal should be realistic. we should not give false hope or something unrealistic to the patient. The goal setting has to be realistic, which the patient will be able to achieve. Then it should be time bound, it should be achievable within a few time, and evaluation should be done at predetermined times to see whether the given intervention is effective and whether the goal has been reached or not. And revision should be done, R for stand for revised, so revision should be done time to time to see whether whether we need to form a new treatment plan or we need to update the goal. So coming to the assessment, as a clinician in the outdoor, we have to assess the patient in detail. We have to take a complete history. We have to do the do the neurological examination, and finally come to the quantitative idea about the spasticity. Few scales are there, like the modified Tardieu scale. We have the modified Ashworth scale, which help in identifying that grade of spasticity. Sometimes it Tardieu scale it helps us in before giving the botulinum toxin for spasticity. So most important question is that when to treat spasticity. Spasticity is a very tricky positive problem a patient of SCI usually comes. So it should only we will treat when it creates problems in activities and participation. It interferes with sleep. It provides too much pain, and when treated, we should not abolish the spasticity. It should reduce to a level of 1 or 1 plus in modified Ashworth score, because sometimes when the spasticity is over treated, the patient who was able to do some functional activities like standing, ambulation, transfer, because of the lower limb extensor pattern, will be unable to do that anymore. So it has its positive effects also, it has negative effects also. So it's very important to identify which muscles need to be treated for the spasticity. Our aim should be to give relief and pain and discomfort, improvement of the posture, facilitation of transfer, sitting, standing and walking, hygiene improvement in areas like perineal hygiene, axilla, groin, all these, and prevention of complications like pressure sores as well as joint contractures. So it will be easier to understand which spasticity we need to treat and which we do not. So advantages, we know that it maintains the muscle bulk, it promotes venous return and reduces edema, it facilitates circulation, it prevents deep vein thrombosis, it prevents osteoporosis, reduces risk of orthostatic hypotension and aids in ambulation, standing and transfer. Disadvantage, it promotes screen breakdown, masks voluntary treatment, sleep disturbances, pain, and it may interfere with the ADL and nursing care. It may prevent ambulation, bed positioning and transfer. So coming to the management, our main should be how can the problem be solved, what are the safety and benefit cost ratios of the chosen treatment, and is the chosen management cost effective. Now before it, there was a tiered approach, that pyramid of management for the spasticity. Now that is obsolete. Our recent approach is a sequential, is a concurrent use of both the invasive and non-invasive procedures. We use them together rather than using a graded or a sequential approach. The distribution of spasticity also guides us in what treatment we need to use. If it is a global spasticity, usually we go for the intrathecal baclofen pump and like that. And if it is a focal spasticity, we can go for botulinum toxin. So 4 important things that we need to mention are the alleviation of noxious stimuli, physical interventions, pharmacological interventions and surgical interventions. So the most important thing in the primary management should be the alleviation of the noxious stimuli. Any patient of spinal cord injury usually have a noxious stimuli like ingrown toenail, urinary tract infection, constipation or a pressure ulcer. So often effective treatment of spasticity is removing any noxious stimuli. Physical interventions like the posture, the patient ideal positioning should be such that it controls increased muscle tone and provides a prolonged static stretch. We can use pillows or footboards to maintain the muscle stretch and prevent joint contractures. We ask the patient to sleep in prone position to stretch the hip and the hip flexors and the knee flexors. Then faulty by tilting the seat of a wheelchair, we can do that. Faulty posture, if the posture is faulty, then it may lead to decreased range of motion, increased spasticity and contracture and pain. So we need to avoid the following postures for any patient of spinal cord injury, like the scissoring posture, which may prevent the perennial hygiene, wind sweat posture in a wheelchair, and the frog leg posture. Therapeutic exercises, we need to do the maintain the range of motion of all joints and give this low velocity sustained stretching for at least few minutes for a longer period, at least 30 seconds for a longer period, like 20 minutes at a stretch. Modalities like cryotherapy, we can use them, but the efficacy is short-lived and intransient in nature. Thermotherapy is there, but neither of the temperature-based modalities have significant evidence. There is no such evidence demonstrating long-term benefit or any functional benefit. We have the TENS, we have the transcutaneous spinal cord epidural stimulation, functional electrical stimulation, leg cycle ergometry. They all help in reducing painful stimuli, but the evidence is not much. Coming to the next point is the splinting, which is very important. We have these upper limb and lower limb tone reducing splints, which help us in maintaining a sustained stretch overnight when the exercises or the therapeutic exercises are not going on. So overnight we can put on a padded ankle foot orthosis. We can put on a hand splint wrist hand orthosis. So they will provide a continuous stretch. Most of the cases of lower spinal cord injury who are not bound to walk are usually given one PLS AFO, like a foot drop splint. But we should always remember that to prevent spasticity, we need to give a night splint or a padded solid AFO, because the patient may not walk, so PLS AFO won't help. Then passive standing on a standing frame or tiltable will automatically stretch the hip, knee and ankle plantar flexors. So after doing all these things, after alleviation of noxious stimuli, positioning, physical modalities, these are the first line treatments. If not improving, or then we can go for the pharmacological interventions. We know that oral medications are there, like the GABA receptor and agonist baclofen, GABA B receptor, benzodiazepines, alpha 2 agonist tizanidine, and dantrolene, which is not available in India. Some emerging drugs like tolperisone and clonidine is there. Baclofen and tizanidine are mainly used in the spasticity of spinal cord injury, and benzodiazepines are no longer the first line drugs. So we have the baclofen, which is a GABA B receptor agonist. We have tizanidine, which is alpha 2 agonist, centrally acting. We have benzodiazepines, which are the GABA A receptor agonist, and dantrolene, I am not going to explain, is not available. So here we can see that if we, this is an overall chart providing, showing that if we want a focal spasticity, the best thing to go for is the botulinum toxin, as well as if we want it reversible and focal, then go for botulinum toxin. If it is focal and permanent, then go for selective peripheral neurotomy, and if it is global and reversible, go for intrathecal baclofen, and global along with permanent, we can go for dorsal root entry zone. Next, coming to the injectable, we have the botulinum toxin. We know that is the most important neurotoxin, and it is 7 serotypes. It acts by mainly the neurotransmitter release of the NMJ, neuromuscular junction. So only A and B are in clinical use, C is in research, and a new variant has been identified as the botulinum toxin X. So this is the mechanism of action. So it is composed of the toxin is made up of the heavy chain and the light chain. We can see heavy chain, this is the heavy chain, this is the light chain. It is taken up by the botulinum toxin presynaptically by the botulinum toxin receptor. Then it is by endocytosis, it goes inside the cytosol. The heavy chain remains bound and the light chain comes out, and it cleaves and deactivates the snare proteins and SNAP25, and ultimately the acetylcholine is not released into the for the motor
entry. Dr. Basu, please sum up. We are function of time.
Some dilution has to be made before giving the reconstitution for the Botox. Dose depends on the depends on size of the muscles, body weight, extent and location, degree of spasticity, response to prior treatment. Adult dose is 600 to 800, starting dose 50%. Guidance methods I'd like to highlight by EMG, US guided electrical stimulation. The advantage of using ultrasound is that by keeping the probe at one place, we can inject so many muscles at the same time. We can inject the medial gastrocnemius, soleus, flexor hallucis longus, and tibialis posterior. So multiple pricks can be avoided using using an ultrasound. After Botox injection, we should not let the patient go without just to go for rest at home, because we need the stretching, we need the occupational therapy, we need the splinting, and some anti-spasticity medications. Usually the spasticity is reduced by 1 grade. Adverse effects are very less, but sometimes injection site pain, localized weakness can happen. Chemical neurolysis like phenol is no longer used now because it is overshadowed by Botox. Surgical, I have skipped in ITV, intrathecal therapy, because it has already been discussed, and surgical management has also been discussed. So this is my neuro rehab center where I lead with my team. This is my team at Rihavana. Thank you.
Thank you, Kaustav. I think we can just have a couple of questions.
What we know, the maximum tolerable or maximum allowable dose per day is 400.
Yes, sir, 400. Sir, I found this in many books that it's written 600 to 800, but the most practiced dose is usually up to 400.
So if we don't have any other questions, we can conclude the session. Thank you, both the speakers, but just a word on the spasticity management, because what I think and what we all have experienced is that spasticity probably cannot be treated. It has to be managed, and it's again a teamwork, starting with the PMS specialists, with the rehab team, and the neurosurgeons when we feel that the patient might need a baclofen pump. So I think it's imperative, as you mentioned, the assessment, the goal setting, and most importantly, we need to use the medicines as judiciously as possible before we hand over the patient to the neurosurgeons if needed for a baclofen pump.
Sir, that main thing is that it should be like an holistic approach, multidisciplinary holistic approach, because all members have their own contributions.
True. Thank you. Thank you so much.